I'd like to next introduce Justin Gottlieb, a surgical retina faculty at the University of Wisconsin, and my husband, I'd like to disclose. And he will be talking to you about the treatment for wet macular degeneration. Thanks.
Good morning, everyone. It's nice to stand up here now. I can look and see everyone. I see a lot of friends from the clinic. They've spent many, many hours waiting for me, waiting to get treatments for wet AMD, which I'm going to discuss today. Again, thank you for your efforts to get here this morning, and hopefully this will be a valuable teaching session for everyone. So let me begin the slides, please. So I also have no financial gain from any of the medications I'll be discussing here. But wet macular degeneration, very simply, is due to the growth of blood vessels, abnormal blood vessels that grow under the retina, causing bleeding and leakage. It's not only the red blood cells that are underneath the retina, but it's the lipids, cholesterol, fluid that come from the blood vessels that lead to a swelling, a thickening of the retina, and cause either wavy vision or may lead to the development of loss of the central vision. So what is the goal of the optimal treatment? What's the best treatment that we can think of? Well, we would certainly want to eliminate, to get rid of those abnormal blood vessels, and or decrease the leakage of blood and exudates. So really, if we can decrease the leakage and then get rid of the abnormal blood vessels, that would be optimal. And as many of you have experienced, over many, many years, we've tried things to eliminate the blood vessels, but it's been very, very difficult. So what are the three major treatments that have been actually tested and proven to be somewhat effective? Those are thermal laser. That's using a hot laser, if you will, hot in that it burns the blood vessels, but it also, unfortunately, burns the retina over top of the blood vessels. There's something called photodynamic therapy, which was tested and was found to be better than no treatment alone, but it wasn't great. And now we have the anti-VEGF or anti-vascular endothelial growth factor medications that we inject into the eye in front of the retina for treatment. So thermal laser, so go back to what we were thinking about, what is the optimal treatment? Yes, it actually eliminates the blood vessels. Now, unfortunately, they often come back, but it eliminated, it destroyed them. But if you can see in this picture that I've added, that white spot in the center is right dead center in the retina. And this person had treatment of those blood vessels, but the retina over those blood vessels also destroyed. So while it helped in the long run, it was very, very dissatisfying. Made our patients very unhappy when I came in and I said, you know, you're seeing not great because of these blood vessels, but I'm going to make it worse today. Didn't fly very well, and none of us felt good about it. And we had these studies that showed, well, in 18 months, you'll be better if I didn't do this treatment. Not many people liked that, because that was 18 months out of often aged patients' lives in which they were actually seen to be worse. But you know, we knew that it would probably help. Now, for blood vessels that are way outside of the center, it can be still effective, although I'd say that it's very rarely used now. I can't remember the last time I did a thermal laser for wet macular degeneration. So the next was a bit of a improvement. This was using photodynamic therapy and a medication called Visudyne. A lot of you may have had treatments with this. Every 3 months, patients received an injection of a medication into a blood vessel. We waited for it to go through the system, and it would kind of collect in the abnormal blood vessels. And then we would shine a laser. Now, this laser didn't cause a burn, but it actually activated this dye to make the blood vessels shrink. And it was pretty remarkable in that it did reduce the leakage, But unfortunately, it always came back. And so patients had years of this treatment. And again, through good studies, we showed that if we didn't treat the eyes, they had a kind of progressive vision loss. And here it slowed it, but ultimately there wasn't much improvement. So this was kind of a great idea. We actually still use this for other eye treatments, but we're rarely using it now alone for treatment of macular degeneration. So sometimes we will use that in some patients with that also receiving injections in the eye. So let's bring us now to what is our current treatment of choice, and that's these anti-VEGF. Again, VEGF is vascular endothelial growth factor. It's a protein that's released by the retina that says, I need new blood vessels. Why is it saying this? Is probably some sort of a repair mechanism in patients who have macular degeneration. But unfortunately, these blood vessels, which are the eye thinks are helping, are actually going to cause damage in the long run. So over about the last 10 years, we've been using 3 medications. Bevacizumab, which his trade name is Avastin, ranibizumab, which the trade name is Lucentis, and finally aflibercept, which his trade name is Eylea. So probably some of you are receiving one of these medications. Some of you may have received all of these medications in the course of a few years. So what do these medications do? Well, they block this protein. They kind of go in and they grab this protein so it can no longer be effective. It stops the blood vessels from growing. It stops them from leaking. But it really doesn't totally eliminate those blood vessels. Plus, it lasts about a month. So many people have to get these shots over and over, but with time, we can often reduce those injections. Now, from the study of, this is for Lucentis, and I can tell you that all 3 medications are generally about as effective. You can see in the orange line at the top, that is the letters of visual improvement. So patients actually had an improvement by over a line when they received Lucentis. And you can see that those were compared. At that time, we didn't have other treatments. So if we didn't treat them, patients lost almost 3 lines of vision over 2 years. So really, there's almost a 4-line difference in these eyes that received treatment. And when we first saw this, it was an aha, yahoo, we're excited about this treatment because for many years, we were just telling patients, sorry, there's not much we can do. So this helps. But I want to address 3 patient fears or myths associated with this. First, patients say, I'm afraid of needles mixing with my eyes. How big is that darn needle? And how complicated is the procedure? Well, the procedure is pretty simple. We set up the supplies alongside the examination chair. We don't have to use much anesthetic except for drops. So we put a number of drops or a gel for numbing of the eye. Importantly, we put betadine, and some of you have learned that betadine can hurt your eyes after a while because it's kind of toxic to the front, but it is the best method of sterilizing the eye. So we put some betadine into the eye to sterilize it. Then we take a cotton tip, a Q-tip swab, and we put more of that drop of the anesthetic right on the tip of it, and we put it right where we're going to do the injection. We hold it there for about 30 seconds. And then we put a lid speculum, something that'll pull your lids and lashes away from the eye. Most of us use this. It's not absolutely necessary. And we ask patients to look away a bit. We put a little more cleaning solution on the eye. So again, we're really fearful about infection, so we really carefully work to prevent that. We draw up the medication. We mark how far from the center we're going to do the injection. And then we actually use it and make an injection right into the eye. And we use what's called a 30-gauge needle. And that's about the size of the needle that people use to give themselves insulin. It's about the size of a medium-sized pin. So it's not painless, but most of you know it's incredibly, incredibly well tolerated. So now we know that, yes, it's not that complicated. So the second myth, I do not want my eye to be a pincushion. Doc, isn't one injection enough? Can't we just solve it with one injection? And unfortunately, the answer to that is no. Multiple injections are needed. Usually we start with monthly injections, maybe 6 weeks, but usually a month to 6 weeks. And then we'll try to extend the time between the treatments. We call that a treat and extend. So we'll get a test every time to see if it looks like it's effective. And when things start looking stable, we may go to 8 weeks, 10 weeks, 12 weeks. We may get back down to 8 weeks because there's a little bit of recurrence. But if we stop too soon, recurrences usually occur and often the vision is drops. Third myth, the risks of using a needle to inject a drug repeatedly into my eye must be very risky. The answer is, amazingly, it's not too risky. Eye infections, which I said we really fear, occur about 1 in 2,000 injections. So yes, they occur, they can be treated, but they're one of the things we really don't want to see occur. The betadine, and a lot of you are gnashing your teeth because you know that betadine causes you to go home and have a very scratchy eye. That is the most important thing. We use it for, when I do major surgeries in the eye, that's all we use to clean the eye, is the betadine. It's amazingly effective. We want you to avoid rubbing your eyes. We don't want you to transmit dirt from your fingers or your own lids into your eye. We have to avoid unclean water, so we don't want you swimming in a pool right after the injections or in a lake. Sterile eye drops only, so even glaucoma drops we usually will hold for a day or two, but we may give you some sterile one-time use drops to moisturize the eye. And antibiotic drops are not needed. We use them at first, but now we rarely use them. And what does this drug, what risk does it have from systemic? Well, large studies have shown that there's a very low systemic risk. There is a risk of stroke, heart attack, but they're very similar to the patients who had sham or placebo injections. Avastin was used as a cancer treating drug as well, and in very high doses, those patients had a lot of side effects when it was given intravenously, but the only 1.25 milligrams, a very small dose in the eye, leads to very low systemic risks. But we want to know, do you have a history of a stroke or a heart attack? And we have to think about that when we're deciding on treatment. So in conclusion, the procedure is very well tolerated. It must unfortunately be repeated often. You're going to get to know your doctor very well. You'll know all about my kids. It's relatively safe, but not 100% risk-free. So there are definitely major improvements occurring in our treatment of wet macular degeneration, and we're researching currently longer-acting medications and ones that are even more effective. Thank you very much.